Hello, everyone, and welcome to today's learning session. My name is David Odige, and in this lecture, we'll be focusing on medications used to treat cataracts, glaucoma, age-related macular degeneration, and Ménière's disease. These conditions impact vision and balance, two systems that are vital for daily functioning, and understanding their medications will help you provide safe, evidence-based care for your patients. Let's begin with Chapter 22, Glaucoma, Cataracts, and Age-Related Macular Degeneration, AMD, are leading causes of vision impairment. Glaucoma involves increased intraocular pressure damaging the optic nerve. Cataracts cause lens clouding, affecting vision clarity. Age-related macular degeneration deteriorates the macula, leading to central vision loss. Understanding these conditions is crucial for effective management and prevention strategies. In cataract management, medications are primarily used to support surgical procedures or reduce inflammation. First, mydriatics, such as phenylephrine, are used short-term to dilate the pupil before cataract surgery. These drugs can cause photophobia, increased intraocular pressure, and tachycardia, and are contraindicated in angle closure glaucoma. Educate patients to wear sunglasses and occlude the lacrimal duct to reduce systemic absorption. Next are cycloplegics like tropicamide. These medications dilate the pupil and temporarily paralyze accommodation. Side effects include blurred vision and burning sensations. Use caution in older adults since CNS effects are possible. Remind patients to avoid driving after administration. Topical nonsteroidal anti-inflammatory drugs such as ketorolac help reduce inflammation but can cause irritation, so check allergy history and use aseptic technique. Topical antibiotics like moxifloxacin prevent postoperative infections, emphasize hygiene, and the importance of following the exact dosing schedule. Finally, corticosteroid eye drops reduce inflammation but can increase intraocular pressure and delay healing. Monitor IOP closely and avoid bottle tip contamination during use. Now let's move to glaucoma medications which aim to lower intraocular pressure. Latanoprost, a prostaglandin agonist, increases aqueous humor outflow. It may cause iris color changes and redness. Instruct patients to remove contact lenses and administer only one drop nightly. Timolol, a beta blocker, reduces aqueous humor production. Because of its systemic effects, it can cause bradycardia and hypotension and is contraindicated in asthma, COPD, and heart block. Teach patients to occlude the lacrimal puncta to reduce systemic absorption. Acetazolamide, a carbonic anhydrase inhibitor, decreases aqueous humor production and is used in emergencies. Watch for electrolyte imbalance and gout and avoid in patients with sulfa allergies. Pilocarpine, a miotic agent, helps open the trabecular meshwork but may cause poor night vision, increasing fall risk. Warn patients to be careful in low light environments. Lastly, hyperosmotic agents such as mannitol provide rapid reduction in intraocular pressure and are reserved for emergencies. Monitor fluid balance and electrolytes carefully. Here we look at treatment options for age-related macular degeneration, or AMD. For wet AMD, medications like ranibizumab, an anti-VEGF agent, are administered by intravitreal injection every 4 to 6 weeks. They stop abnormal blood vessel growth. Patients may experience temporary redness or pain and require strict sterile technique. Another treatment for wet AMD is Verteporfin, used in photodynamic therapy. It is activated by laser after intravenous administration. Because this medication reacts strongly to light, patients must avoid direct sunlight for at least 5 days after treatment. For dry AMD, oral nutritional supplements help slow disease progression. These may interact with anticoagulants such as aspirin or warfarin. Encourage patients to eat leafy greens and stop smoking to maximize benefit. Chapter 23 covers medications used to manage Meniere's disease, a chronic disorder affecting balance and hearing. Antihistamines like meclizine and diphenhydramine help reduce vertigo, nausea, and prevent attacks. They sedate the vestibular system but can cause drowsiness, dry mouth, and blurred vision. Use caution in glaucoma and urinary retention. Implement fall precautions and advise patients to avoid driving during treatment. Anticholinergics such as scopolamine reduce vestibular nerve signal transmission, lowering sensitivity to motion. Side effects include dry mouth, blurred vision, and constipation, and it is contraindicated in angle closure glaucoma. Apply patches behind the ear and monitor for confusion, especially in older adults. Next are additional medication categories used in Meniere's disease. Benzodiazepines, such as lorazepam, help control vertigo and anxiety during acute attacks. They depress the CNS, so watch for sedation, hypotension, and respiratory depression. These medications should be used only short term. Monitor respiratory rate and level of consciousness. Antiemetics like ondansetron help reduce nausea and vomiting during vertigo episodes. They block serotonin receptors and may cause constipation or headache. Monitor hydration status and electrolyte balance. Finally, oral diuretics help reduce endolymph fluid pressure in the inner ear. They are used long term to prevent attacks. Side effects include electrolyte imbalance and dehydration, so daily weights, intake/output, and monitoring for hypokalemia are essential. Encourage a low salt diet, which significantly helps reduce symptoms. Thank you for your attention. We hope this presentation has enhanced your understanding of the subject. Please feel free to reach out with any questions